After having seen several cases that belong to category 1B crushed stone-like or pleomorphic calcifications, that is when the mammogram heavily underestimates the extent of the disease, let us see the natural history of this subgroup. That is, unfortunately, the originally grade 1 and grade 2 cancer in situ may progress to grade 3, may progress to poorly differentiated invasive carcinoma. We can study the natural history on this case of an asymptomatic 50-year-old woman. These two clusters of obviously malignant type calcifications were either not perceived or they were ignored. 24 months later, the calcifications are very easy to perceive. However, the analysis is very difficult because the calcifications have high density, even in density, and they are smooth contoured, kind of giving the impression that these are benign type calcifications. However, if we look at the previous mammogram and compare the shape, the density, and the size of these calcifications, their closeness to each other, their distribution in terminal ductal lobular units, and then we think about that might have been a grade 2 in situ carcinoma, then more necrosis was added to the already necrotic material, and therefore the radiologist is fooled because the longer we follow up these calcifications, the more necrosis makes the calcifications look smooth contoured, benign looking. Additional 23 months later, however, the calcifications start to fade away. We know at this time point that the stromalysin 3 enzyme is active and it has the ability of opening the basement membrane. We see the non-specific asymmetric density, most probably accounting for initial invasion. But it can also dissolve the calcifications. And it's exactly that happened in this case. An additional 19 months later, we can ask the question, where are the calcifications? They have been very successfully dissolved. Unfortunately, the disease didn't disappear. The disease comes back another 19 months later. It has already de-differentiated. The calcifications are that of the rod-like casting type, filling in ducts and their branches, and as we see, here is an ill-defined density, architectural distortions, long calcifications drilling in all direction, and there are these crushed stone-like calcifications as well. We can read out of this series of images what happened in the breast. At the first examination, it was so easy to make the diagnosis. Most probably, perception was improper. At the second examination, no perception problem, but differential diagnostic problem. The warning signal is at the third examination. One should think about that missed malignant type calcifications. When they start to disappear, invasion starts. And the invasion appeared at the fifth examination. And now the patient has a frank invasive carcinoma. And as we know, in 60% of the cases associated with the branching casting type calcifications, the invasive carcinoma is grade 2. But the most important component of this disease is indeed the drilling ducts, the neoduct genesis, that might jeopardize the patient's life. This is actually, in reality, a grade 3 or poorly differentiated invasive duct-forming carcinoma. She had node positivity. She went through mastectomy, postoperative irradiation. She was put on tamoxifen. Fortunately, 12 years later, she doesn't have any sign of recurrence. Nevertheless, the teaching point is very clear. Whenever we see a cluster of crushed stone-like calcifications, we can think about that the case belongs to category 1b, that is, when we heavily underestimate the real extent of underlying disease. In any case, whichever category the case belongs to, we should arrive at the microscopic diagnosis.